Very good morning. I'm Dr. Siddharth David, Senior Lecturer in the Department of Public Health Dentistry, BPD Coach, BPDU, and I will be taking a lecture on atraumatic restorative treatment for BDS fourth year students. The contents for today's lecture are introduction, indication and contraindications, instruments and materials, principal steps involved, advantages and limitations, conclusions, and preferences. Introduction. Although dental caries have substantially decreased in industrialized countries, it remains to be a widespread problem all over the world. Most of the patients with carious state in developing countries tend to go untreated to such an extent that the only treatment option available is extraction. In developing countries and certain special groups, such as refugees and people living in deprived countries, there is a lack of restorative care because it is not possible to reach remote populations with modern dental equipment. Acute shortage of trained personnel, lack of electricity, the inadequate motivation of rural communities due to lack of education and information, fear of dental treatment. The definition of atraumatic restorative treatment, according to the American Academy of Pediatric Dentistry, is a dental caries treatment procedure involving the removal of soft and demineralized tooth tissue using hand instruments alone, followed by restoration of the tooth with an adhesive restorative material, routinely glass iron cement. The technique of ART was pioneered in Tanzania in the mid-1980s by Dr. Joe Frenkel. In April 1994, the World Health Organization introduced ART as a part of the World Health Day. Now we'll be talking about the principles of ART. The procedure is based on the following principles: removing caries using hand instruments only, restoring the tooth with an adhesive filling material, glass and resin. The indications and contraindications for ART. In general, ART is carried out only in the small and shallow cavities involving the dentine that are accessible to hand instruments. Introducing oral care to very young children not previously exposed to dentistry. For patients with extreme fear or anxiety, for the homebound elderly and those living in nursing homes, for mentally or physically challenged or handicapped patients, in high-risk caries clinics as an intermediate treatment to stabilize conditions. ART is not used when there is an abscess, swelling near the carious tooth, the pulp of the tooth is exposed, carious cavity not reachable with hand instruments, teeth have been painful for a long time, and there may be chronic inflammation of the pulp. These are the instruments and materials used in ART: mouth mirrors, explorers, pair of tweezers, dental hatchets, small and medium size spoon excavators, carvers, pliers, glass slabs, and spatula. Now we'll be talking about the operating light. The light source can be natural or artificial light. It is more reliable, constant, and can also be focused on a particular spot. In a field setting, a portable light source is recommended. Example, a head lamp. Now the materials used for ART. The materials we would be requiring are gloves, cotton wool rolls, cotton wool pellets, plastic strips, wedges, glass ionomer restorative material, dentine conditioner, petroleum gel. Operators' work posture and positions. Now these are the postures or the positions that the operators sits and performs the treatment. The operator sits firmly on a stool with straight back, thighs parallel to the floor, and both feet flat on the floor. The range of positions are from 10 to 1 on the clock. Most commonly used positions are direct rear position, that is the 12 o'clock, or right rear position, which is a 10 o'clock position. Now we will be talking about the principal steps of AR. The first and the foremost and the primary step in any dental treatment is isolation. We isolate the tooth with cotton wool rolls and then we prepare the cavity. The cavity is prepared by removing the plaque from the tooth surface with a wet cotton wool pellet and then we dry the surface with a dry pellet. If the cavity opening in the enamel is small, we widen the entrance by placing the blade of a dental hatchet into the cavity and turning the instrument. Caries technique is with the excavator by making circular scooping movements around the long axis of the instrument. Overhanging enamel must be removed with the blade of the dental hatchet. Place the instrument at the edge of enamel and fracture of small pieces. Cleaning the prepared cavity. In order to improve the chemical bonding of glass ionomer to the tooth surfaces or the structures, the cavity walls must be very clean. A dentine conditioner is used. The liquid supplied with the glass ionomer itself can be used. Mixing of the restorative material. Mixing should be completed within 20 to 30 seconds. Depends on the brand of the GIC cement we are using. Placing the mix. Insert the mixture into the cavity in small amounts using the blunt end of the applier carver instrument. Rub a small amount of petroleum jelly on the gloved index finger and press the soft restorative material firmly on the cavity and fissures. The press finger technique. The excess material is removed with a carver. We cover the ART restoration with a new layer of petroleum jelly, and the patient is not allowed to eat for at least 1 hour. The advantages of ART. It is easily available and relatively inexpensive hand instruments are used rather than expensive electrically driven dental equipment. The limitation of pain, thereby minimizing the need for local anesthesia. A straightforward and simple infection control practice without the need to use sequentially autoclave handpieces. The chemical addition of glass iron that reduces the need to cut sound tissues for retention of the restorative materials. The leaching of fluoride from glass iron, which prevents secondary caries development and probably remineralizes caries dentin. The combination of a preventive and curative treatment in one procedure, the low cost. The limitations of ART, long-term survival rates for GIC, ART restorations and sealants are not available, limited to small and medium-sized one-surface lesions. The possibility exists for hand fatigue from the use of hand instruments over long periods. Hand mixing might produce an improper mix varying among operators. Conclusion. ART is a minimally invasive and patient-friendly technique which can be adopted as a primary healthcare approach due to its less sophisticated nature. It makes restorative care more accessible for all populations. Further, improvements in the mechanical and adhesive properties of the new GICs are required to ensure their optimal long-term clinical performance. These are the references for the presentation. Thank you.